My name is Nicole Arellano, and this is my video presentation on dyspnea. What is dyspnea? According to the American Thoracic Society, dyspnea is a subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity. This derives from interactions among multiple physiological, psychological, social, and environmental factors, and may induce secondary physiological and behavioral responses. The prevalence of dyspnea is 9 to 13% in the community and increases up to 37% for adults aged 70 years or more. It is a frequent cause for emergency room visits, which accounts for 3 to 4 million visits per year. Dyspnea can arise from different contributory respiratory sensations. It can arise from a variety of pathways, which includes afferent signals, efferent signals, and efferent-reafferent mismatch. Afferent signals trigger the central nervous system, specifically the brainstem and cortex. The sense of air hunger is derived from signals coming from peripheral chemoreceptors in the carotid body and aortic arch, and central chemoreceptors in the medulla. These are activated by hypoxemia, hypercapnia, or acidemia. The sense of chest tightness is derived from signals coming from the mechanoreceptors found in the upper airways, lungs, and chest wall. These are activated in the setting of increased workload. Efferent signals are sent from the central nervous system, particularly from the motor cortex and brainstem, to the respiratory muscles. These are also transmitted by corollary discharge to the sensory cortex, which produces the sense of respiratory effort and contributes to the sensation of air hunger. In assessing dyspnea, the Modified Medical Research Council Dyspnea Scale is used. It is graded from 0 to 4, depending on the perceived breathlessness of the patient in correlation to the activities done. Grade 0 is when there is breathlessness only with strenuous exercise. Grade 1 is when there is shortness of breath with walking on level ground or on a slight hill. Grade 2 is when the patient walks slower than people of the same age on level ground, or when the patient has to stop to rest when walking at own pace on level ground. Grade 3 is when the patient stops to rest after walking 100 meters or after a few minutes on level ground. And grade 4 is when the patient is too breathless to leave the house or do activities of daily living. Approximately 85% of dyspnea is due to pulmonary or cardiac conditions. Under pulmonary, this could be due to airway disease such as asthma and COPD, parenchymal disease such as an interstitial lung disease, and chest wall disease such as presence of bony abnormalities like kyphoscoliosis. Under cardiac, this could be due to left heart dysfunction such as coronary artery disease and cardiomyopathy, pericardial disease such as restrictive pericarditis and cardiac tamponade, and diseases affecting pulmonary vasculature such as pulmonary hypertension. Other causes include anemia, deconditioning, and psychological processes such as anxiety. In approaching a patient with dyspnea, history, physical examination, and workup are all considered. In history taking, it is important to know if there is already a known condition or not. If there is, evaluation of the condition should be done and assessed if there is progression or if there is a new process that could have caused the dyspnea. This could be of pulmonary, cardiac, or neuromuscular etiology. Onset, duration, and pattern of dyspnea must be noted. Acute intermittent episodes can be seen in myocardial ischemia and bronchospasm. Chronic persistent dyspnea can be seen in COPD and interstitial lung disease. The characteristic and quality of sensation must also be noted. For example, chest tightness may be due to bronchoconstriction, and sensation of inability to take a deep breath may be due to COPD. Effect of position on dyspnea and associated symptoms such as orthopnea, platypnea, and nocturnal dyspnea must also be noted. Other risk factors must be asked since there are dyspnea that can be drug-induced or due to occupation. On physical examination, the patient must be assessed if he or she is in respiratory distress. Vital signs must also be checked. Fever may suggest an underlying infection or inflammation. Increased blood pressure may suggest heart failure or diastolic dysfunction. Tachycardia may be associated with fever or may suggest cardiac dysfunction. Presence of resting hypoxemia may be seen if there is hypercapnia, ventilation-perfusion mismatch, or impairment in diffusion capacity. Exertional oxygen saturation must also be taken to reproduce symptoms, also to assess for new findings that were not present at rest, and for changes in oxygen saturation. Pale conjunctiva may indicate presence of anemia. Cyanosis and alar flaring may indicate pulmonary disease. On chest and lungs examination, it is important to take note of any use of accessory muscles and symmetry of chest movement. On percussion, dullness may suggest pleural effusion, and hyperresonance may suggest emphysema. On auscultation, prolonged expiratory phase, diminished breath sounds, wheezes, and rhonchi may indicate airway diseases. Rales may suggest edema or fibrosis. Cardiovascular findings such as jugular venous distension and accentuated pulmonic component of S2 may indicate elevated right heart pressure. Murmurs may suggest presence of valvular disease. Abdominal findings include paradoxical movement of abdomen, presence of increased respiratory distress in supine position, inward motion during inspiration seen if there is diaphragmatic weakness, and rounding of abdomen during exhalation seen if there is pulmonary edema. For the workup, chest X-ray may reveal hyperinflation seen in obstructive lung disease, low lung volume seen in interstitial edema, consolidation and infiltrates seen in interstitial disease, prominent pulmonary vasculature in the upper zones and enlarged central pulmonary arteries seen in pulmonary hypertension, enlarged cardiac silhouette seen in dilated cardiomyopathy or valvular disease, and presence of effusion seen in heart failure or carcinoma. Chest CT is indicated in cases wherein the diagnosis is still uncertain. Laboratory studies include hematocrit to check for anemia, arterial blood gas to check for metabolic acidosis seen in chronic respiratory failure, ECG to check for ventricular hypertrophy and myocardial infarction, spirometry to check for presence of an obstructive disease such as COPD and asthma, echocardiography if systolic dysfunction, valve disease, or pulmonary hypertension is suspected, and BNP if patient presents with acute dyspnea to assess for heart failure. Cardiopulmonary exercise test or CPET is taken to determine if the cause of the exercise limitation is due to a respiratory or cardiovascular problem. Respiratory, if at peak exercise and predicted maximal ventilation is achieved, there is an increase in dead space or hypoxemia, or if the patient develops bronchospasm. Cardiovascular, if heart rate is more than 85% of the predicted maximum, anaerobic threshold occurs early, blood pressure becomes excessively high or decreases during exercise, O2 pulse falls, or if there are ischemic changes seen on the ECG. For treatment, the primary goal is to correct the underlying condition and address the potentially reversible causes. If this is not achieved, the goal is to lessen the intensity of the symptom and its effect on the patient's quality of life. Supplemental oxygen is given if the resting oxygen saturation of the patient is less than or equal to 88%, or if it drops to this level with activity or sleep. And opioids may also be considered based upon the risk-benefit profile to reduce symptoms of dyspnea. That wraps up my video presentation on dyspnea. This is my reference. Thank you.